My name is Ariana Campbell and I am a PA. I work in emergency medicine in Northern California. I live and work in a rural community in Northern California and work at a rural hospital.
I am Brittany Stokes Francis from Baltimore, Maryland. I specialize in urgent care and primary care medicine.
My name's Jeff Myers. I am a PA in inpatient palliative care and work in palliative and hospice medicine. And I work out at Oregon Health and Science University in Portland, Oregon.
My name is Deborah Dunn. I'm a physician assistant. I work at Chase Braxton Health Services in Baltimore, Maryland, Columbia, Maryland, and the Eastern Shore. My expertise is in transgender medicine.
My name is Kevin Luong, and I'm a PA in Pittsburgh, Pennsylvania. I work for the University of Pittsburgh Medical Center Health System in pain medicine.
I have been a PA for 22 years now.
For 10 years now.
I am coming up on my 15 years of being a PA this year.
I have been a PA for 8 years.
This is my 40th year anniversary.
I wanted to be a PA because I really wanted to make a difference in patients, and I realized that I didn't have to necessarily go to medical school to do that, and went to my first PA when I got sick before college, and was like, wow, that's who I could be, and they're doing all that I want to do.
I wanted to be a PA because I wanted to work in medicine, but to tell you the truth, with a lot of motivation from my mother.
I wanted to work in pain medicine because I see that pain and suffering is something that is unavoidable for pretty much all of us. And I wanted to focus on something that I can help and play a role to make a difference in people's lives.
Well, I knew that there wasn't access to care for people who identify as transgender and non-binary. And as I started working at Chase Braxton, I realized how important it was to be able to allow people to have quality of life.
I early on identified where PAs were, my ability to see and treat patients, to see people on their worst day and make it better, and the impact I could have on the patient and their families, and the ideals of PAs as part of that team where we're able to provide excellent care to patients at their worst hour.
Opioid medications are an important tool for healthcare providers, and it's important for us to do it responsibly.
In palliative and hospice, opioids are definitely a part of our tool. We not only use them for pain, but sometimes we'll use them for shortness of breath. So they're definitely a go-to for a lot of symptoms that we try and manage. And so really making sure that we're avoiding misuse is really a big factor for us, because they're often on a lot of other medications that can interact not so friendly with opioids. And so we really have to consider all the risks, weigh the benefits, and really have hard conversations with our patients.
The usual pain that my patients have are emotional. There's anxiousness and depression that are palpable to me. And all of these are causes of physical pain, so they do also complain of physical pain. If they legitimately have an injury, a fracture, cancer, things like that, I will prescribe opiates. But at the same time, I'm referring them to specialists to take care of their pains.
I can tell you, I see people, again, on their worst day, where they have suffered a very painful, traumatic injury. And I will treat them aggressively, and many times with opioids, because that is sometimes the best medicine that I can give in an acute, painful situation.
My biggest concern about prescribing opioid medications is not to be a part of the problem. I don't want to be afraid of the medications because they have their purpose, but I don't want to be too comfortable either.
My role is education. I have heart-to-heart conversations with my patients on a regular basis where I treat their pain aggressively, and I will tell them if I think that there could be an issue. I will let them know. I'll talk to their family if it's an adolescent, for example, that I really try to limit the amount of opioids I give in follow-up, that we want to use alternatives to opioids as often as we can. We want to decrease exposure to opioids, especially in adolescents. And we don't want to continue opioids for a long period of time after we initiate, so that we can avoid folks going through a withdrawal or prolonged exposure to opioids certainly can lead to longer-term problems and misuse in some cases. But I also want to make sure I keep the patient at the center of this, address their pain needs, and provide appropriate prescriptions and education for them.
When I first started practicing, it was very scary. To go into a room where you've done your research and this person has had a lot of use, you feel like the person is going to be very angry at you if you don't give them what they want.
The main goal from the beginning to end is to maintain professionalism since we're in the healthcare field. And the second thing is to try to talk to patients in a way that they can understand and appreciate the rationale for what we are doing. The goal is to help patients understand that we are trying to help them in a way that will also keep them safe. If we don't practice that, then we can also put them at risk for addiction and even death if we're not careful.
If I think somebody may be struggling, maybe taking more than prescribed, I'll have an open, honest conversation with them and let them know there's options for treatment, there's no judgment, there's ways we can get through this, there's other medications that are safer. And so it's really having that conversation, that connection with somebody that can make a really big difference.
So some of the ways that we really try and approach opioid discussions and really trying to prevent misuse of them, especially if we've done some screening, which is kind of the first place to go to, is doing some basic screening. In the palliative population, it's not usually studied very well, but we often will use things like the opioid risk tool, the SOAP-R tool, and it's trying to pull out and determine just how risky things are.
So in my practice with pain medicine, there are certain tools and practices that we use to prevent or at least curb the opioid misuse. In terms of tools, we use the opioid risk tool, or we can use the current opioid misuse measure, the COM score, or we can use the screener for an opioid assessment for patients in pain.
There are several tools that I use to try to prevent opioid use disorder, from the CRISP, which is the local database that I can investigate previous use, from printing education to the patients, also just the local pharmacists and primary care providers so that they have the information of what we provided to their patient, and the pharmacist that can provide adequate education on the medication, so that way the patient has all the tools that they can be successful in use and hopefully not end up in a place of opioid use disorder.
I will say that if we have somebody who's in a more higher risk category, we will partner with our addiction medicine colleagues, our colleagues in pain management, and really not only to try and find lots of other multimodal opportunities to treat their pain, making sure that we're addressing their total pain, their anxiety, depression, those things that are contributing, but really making sure that we're also addressing that physical pain in the safest way possible using our kind of multidisciplinary approach with other specialty groups.
I, for a long time, would see folks struggling with substance use disorders and didn't really incorporate it into my daily practice. I thought it was somebody else's job.
It's certainly not easy because opioid misuse can come in any shape or form. The best that we can do is apply all the tools and strategies that we can be aware of so that we can prevent the misuse from happening.
One of the biggest challenges is that there's not access to health care. There's no access to mental health services for people who identify as LGBTQ. At where I work, we do have a very good addictions department, and we do have really good behavioral health that do understand and specialize in gender medicine and people of different sexual orientation. But I find that because it's not commonly taught in any medical curriculum, I really don't have an outside source or a lot of barrier to health care for these patients because of a lack of access to care.
I also kind of found out a hard way that, families can also misuse their medications as well. One particular case was realizing from a hospitalization that the patient wasn't needing their medications while they were there in the hospital, but their son was asking for a refill. That was a big trigger for me. And so I think it really kind of caused me to pause pretty early in my career that, wow, while we should trust our patients and the majority are there doing the right thing, we have to also make sure that it's not just our patients, but maybe a caregiver or family that may be misusing and taking advantage of a situation. And we've got to really be responsible prescribers and make sure, wow, was I not treating that patient's pain appropriately?
We all got into medicine, I think, so that we could help folks realize positive change in their life. And that moment, when you see somebody and they're struggling and they have many times an issue related to their substance use disorder, to be able to offer an opportunity, a way out, a change in their life, a change for health, it's really changed how I see our role in medicine and the power of what we can do at that one moment.